Hey guys, going through a tough phase. I will say no need to worry, bro, because at some point of time we all were here. We all did it. If we can do it, so can you. Okay. So this is Dr. Shivaam signing in, and in this video we'll discuss some high-yielding stuffs regarding surgery, and it will also revise some of the important topics for you. Okay, so starting with the gastric ulcer, there is one classification, if you know, called modified Johnson's classification. According to it, there are four types of gastric ulcers. Okay, in type 1, the ulcer is along the lesser curvature of the stomach, and in type 2, it consists of both the gastric as well as duodenal ulcer. The type 3 is pyloric ulcer, that is, it is just 2 centimeter around the pyloric end. Type 4 is 2 centimeter around the gastroesophageal junction, and type 5 is related to NSAID intake. So very fast we will revise it. Type 1 is along the lesser curvature and it is associated with it is not associated with the acid secretion. Type 2 is in the body along with duodenal ulcer, that is type 2 is gastric as well as the duodenal ulcer. So you can see here in this diagram gastric as well as duodenal ulcer. Type 3 is this one, pre-pyloric. Type 4 is along the 2 centimeter of gastroesophageal junction, and type 5 is NSAID induced. So among them, type 1 is not associated with acid hypersecretion, type 2 is associated with acid hypersecretion, and type 2 and 3 both are associated with acid hypersecretion, and the 5 is associated with NSAID intake. So this Johnson's classification is important. They can give you a figure and ask you which type of gastric ulcer is this. Another important topic from which they frame question is Meniere's disease. So do Google it and study or revise your notes about this Meniere's disease. So what happens is they have hypertrophic gastric folds along with hypoproteinemia and foveolar hyperplasia. Now another important section is the anatomical division of liver. So they do ask from this question, from this part of your anatomy, because it is included both in surgery as well as anatomy. So if you see, this was the simplest diagram I could find for you to make you understand. So you see here, if you see it, the left lobe and the right lobe are divided, and the left lobe is mentioned 2, 3, 4A, 4B, then 5, 6, 7, 8. So I'll make you understand with a easy thing. If this is your right hand, if you make it a wrist like this, so the thumb will go inside. Okay, so you see now, so this thumb is your caudate lobe, okay, which is hidden inside. So this caudate lobe is 1. Okay, so if you can see it, I have written it 1. Okay, this one is 1. Now second lobe is this. Your index finger, the proximal phalanx is second lobe. This is the third. Okay, and this is the 4A and this is the 4B. Now if you go from this side, the right lobe, it moves clockwise. Okay, 5, 6, 7 and 8. Sorry, 5, 6, 7 and 8. 5, 6, 7, 8. So you make a wrist, face it towards you. I am not going to injure you by this, just to explain you. So this is the caudate lobe. This one is 2, 3, then 4A, 4B, then 5, 6, 7, 8. So this diagram will suffice. And few things, there are 2 lines. If you see, this is the Cantel's line. So this is basically a avascular plane in which by which you can divide it, the liver, you can divide it. This line passes through gallbladder and the inferior vena cava. So this Cantel's line is important, and the other is falciform ligament, which is between this. So falciform is between this part is the falciform, 2 and this 3 and 4A, 4B, while the Cantel's line is between Cantel's line is between this one, that is 8, 5 and this 7 and 6. Okay, so this is Cantley's line. Other thing which they can ask is about the lobes. So if you see the medial lateral, this one, so this is the left lobe, this is the right lobe. Now if I ask you which segment is left lateral, so left lateral will be 2 and 3. This horizontal plane is formed by the portal vein. Okay, so 2 and 3 are the left lateral lobes. 4A and 4B are the left medial lobes. If you see this one, so this one is the right lobe. So right medial is 5 and 8. So whenever they ask you question, you just draw this lever diagram so that you don't mistake it. So right medial is 8 and 5, right lateral is 7 and 6. Sometimes they may also change it to right anterior and right posterior. Okay, so same way it is there, right anterior and right medial, right posterior and right medial and right lateral. So this classification was important, so I gave some time to it. Now moving to another, that is the kidney stone. So they are very fond of asking you this kidney stone. So it is a high yield topic for you for your Neet PG. Revise it from your notes and do see their images. So just for your revision, I have given it how they look like, but I would say to go in detail of every stone and study it properly. Okay, so McNeil zones for prostate. One question they ask very frequently is that which part of the prostate is most frequently involved with cancer. So if you see, the peripheral zone of prostate is associated with 60 to 70% of prostate cancers. Okay, so this peripheral zone forms 70% volume of the young prostate and it is associated with 60 to 70% of CA prostate. Transitional zone is associated with benign prostatic hyperplasia, while the peripheral zone is associated with cancer. If you see a mnemonic, easy way to remember, P and P. P for prostate and P for peripheral zone. For cancer, you should remember PP, that is prostate in case of prostate, peripheral zone, PP in case of carcinoma prostate. Okay. Now another important thing which they can ask is to differentiate between the brachial cyst and the thyroglossal cyst. Now you should know where they lie, what are they. So brachial cyst is basically these are the congenital epithelial cysts which are present along the lateral border of the sternocleidomastoid, lateral part of the neck, and along the sternocleidomastoid, basically at the junction of middle and the lower 1/3 of the sternocleidomastoid. Okay, so this will be a swelling, a non tender on painless swelling, fluctuant swelling along the sternocleidomastoid. Okay, at the lower 1/3 and the inferior 1/3. So what are they? These are basically what happens at the 4 weeks of gestation is that the development of 4 brachial clefts results in 5 ridges known as brachial arches. ये brachial arches हमारे different parts of neck को बनाते हैं. So होता क्या है, brachial cyst कब बनते हैं? अगर there is failure of obliteration of second brachial cleft. Okay, so you have to remember second brachial cleft. If there is failure of obliteration of second brachial cleft, it will result in brachial cyst. Now what are thyroglossal cysts? Thyroglossal cyst will be a midline swelling, and these are basically remnant of thyroglossal duct. Okay, and these are midline swelling. What you have to remember about this is, before operating these thyroglossal cyst, the operation name is another MCQ known as cyst trunk operation, where you remove whole of the cyst along with the tract and a part of hyoid bone. Okay, so removal of part of hyoid bone is important in case of cyst trunk. But what preoperative investigation is important for cyst trunk is you have to do an ultrasonography to find whether this thyroglossal cyst contain thyroid or not, because if you remove this thyroglossal cyst, you may accidentally remove the thyroid from the patient. So you have to rule out whether there is thyroid gland in this thyroglossal cyst or not. In that case, you will be little careful. Another thing is, this thyroglossal cyst may also contain CA. So another important MCQ is, what type of carcinoma, thyroid carcinoma, is seen with thyroglossal cyst? I want you to comment in answer, otherwise I'll mention it in my comment section. Now different hernias are very important regarding to the surgeries, like Medial hernia. I'll start with medial hernia. In medial hernia, what happens is you see a W pattern. Now if they give you like this W, you will promptly answer it as medial hernia. What happens is here a loop of bowels goes into the hernial sac like W, and the chances of strangulation are very high, because whole of the bowel loop is lying inside the hernia sac. Now what are the other different rare hernias like sliding hernia? In this, a part of sac wall is formed by the intra-abdominal viscus like this. The figure is not very clear. In the coming figures you will understand. In amyland hernia, A for appendix, A for amyland. Appendix goes into the hernia sacs. That means the appendix forms a component of hernia. So amyland, A for amyland, A for appendix. Little hernia, what happens here? Meckel's diverticulum goes in spite of appendix. Meckel's diverticulum goes into the hernial sacs. And the other is Richard's hernia, where only a part of bowel, you can say the anti-mesenteric border of the bowel, goes into the hernia sac, not whole of the bowel. So the chances of strangulation is less, but yes, gangrene can occur. Now this is the little hernia. Here you can understand it more properly. The Meckel's diverticulum is going into the hernia sac. One more hernia is there, Spigelian hernia. What happens is there is a defect in Spigelian fascia. ये Spigelian fascia क्या होता है? ये aponeurosis होता है transversus abdominis muscle का. तो यहाँ पे defect होता है. उस defect के through a part of this gut goes inside, but not whole of them. Okay, so you will find a lump like swelling here, and like this. See, only a part of gut or whatever you can say is going inside through the fascia, through defect in the fascia. And what fascia it is? Transversus abdominis. So aponeurosis of external oblique and transversus abdominis muscle. Now Richard's hernia, again I already explained, anteromesenteric border only goes into the deep inguinal ring, and the chances of intestinal obstruction are less, but gangrene of the bowel may occur. Okay, now moving to another types of hernia. The Richards already explained, amyland explained. This one, yeah, pantaloon or dual or Romberg or saddlebag. So here what happens, both direct as well as indirect hernias are present. So if they are present simultaneously, you will call dual or pantaloon or Romberg or saddlebag. Okay, so this one, so both simultaneously you can see. And then Spigelian fascia from the tip of 9 costal cartilage up till the pubic tubercle. So here you can see a herniation. Now this is just a figure to explain you exomphalos major, where a umbilical cord is attached to the inferior aspect of the sac. Now moving to other important thing, ulcers. Regarding to the general surgery, they may ask you these type of things, like you have read about erythema induratum. So what is it? It is basically a reaction to the Mycobacterium tuberculosis species. So what happens is, on the calf region you experience these type of lesions. So this, if you see this type of figure, it will be erythema induratum. Now this is a figure of ulcer which is not related to sexual mode of transmission. So these are the Lipschutz ulcers associated with fever, lymphadenopathy, seen basically in the Behçet's disease. So Behçet's disease is another important topic, right from your medicine up till the surgery. It's an equally important topic. Now Melanie or burrowing ulcer. So these basically what they have asked is ki how they are caused. So they are caused by synergistic action of two bacteria. One is microaerophilic non-hemolytic streptococci, other is aerobic hemolytic streptococci. Microaerophilic non-hemolytic and aerobic hemolytic, okay, streptococci. So this figure shows you a burrowing or the Melanie ulcer. Now rodent ulcer, you all know, location you all know, basal cell carcinoma you all know, snail track appearance of syphilis in this figure. Now can you tell me the ulcer here, So this is basically a rare form of ulcer, but you should know that it is martorell ulcer, a form of hypertensive ulcer that is seen with hypertension and atherosclerosis. So martorell ulcer is an important one for you. Trophic ulcer, bed sore ulcer, painful one. Marjolines ulcer, you all know कि it is caused by a chronic ulcer or a chronic trauma which is there for a long time, and what happened is their squamous cell carcinoma has shown up. So marginal ulcer is a long standing chronic ulcer having squamous cell carcinoma. Tuberculous ulcer will look something like this. Punched out ulcer will look like this. Undermined ulcer this. So general surgery is equally important for you. Now some of the basic instruments I have already discussed, but this to give you just general idea again. Ellis tissue used to hold the tough fascias. It has sharp tooths. This one is the towel clip. You must have seen it during your internship days. Backhorse towel clip. Surgical blades, you must know different type of blades, different numbers, and the use of them. So I'll do it in a separate video, and if you can just Google it, it will be good for you. Doyen cross action towel clip. Giggly saw. So this wire, don't get confused if they give you, because it's a very useful. It's used in different types of surgeries to cut the bone and in amputation surgeries as well. Now this is the just a cutting seizure, suture cutting, iris suture seizures, Kelly's hemostatic forceps to clamp large vessels, Koch's forceps, it is quite strong, grabs heavy tissues, toothed, like if I give you example in hemithyroidectomy, you clamp the remaining part of the thyroid tissue with this and just suture it. Okay. Now Lister's bandage seizure, for cutting the bandage, it has a curved end. Lister's sinus forceps. So this is a very beautiful, long and sleek instrument just to gauze or clean the abscess and do the incision drainage by Hilton methods. Maryland forceps, laparoscopic surgery forceps. Nowadays people are very fond of learning and doing laparoscopic surgeries, so their instruments are very important. Do revise them. Now Mayo's or the suture scissors for cutting the tough structure, and if you want to cut fine delicate, so it will be like this, fine long fine scissor known as medicine bomb scissor to cut delicate tissue. Mosquito, you all know. Needle holder, you all know. Non-tooth forceps, Rampley's swab holding forceps. Okay, so it will look like this. Now this is one needle. They have asked this previously. Seldinger's needle, arteriography. Now regarding the suture material and the sutures, I know it is very important for you, and many of you has demanded about this suture video. So I have decided to make another video over the suture materials only. So because it is a quite big topic and you need to have a detailed idea of everything so as to answer whatever question they ask you. So this is the end of this video, and I'll continue with the sutures and everything else in the next part of my video. Till then, stay happy, study hard, stay motivated, and this is Dr. Shivaam signing off. Thank you.